Hi, my name is Seth Baum. I'm a preventive cardiologist, past president of the American Society for Preventive Cardiology and the chief scientific officer for Flourish Research. I'm very happy to be here today to discuss Lp(a) with my friend and colleague, Matt Budoff.
And I'm Matt Budoff. I'm a cardiologist, a preventive cardiologist at UCLA, and also been involved in a lot of cardiovascular research and early detection of heart disease research for many years now.
That's great. So let's start our conversation. First of all, Lp(a) is getting a lot of attention lately. It's in a number of clinical trials, phase 3 and phase 2 clinical trials, and actually a new phase 3 is about to start. Matt, you've done so much work in coronary artery calcium scoring and connecting the dots of elevated Lp(a). Maybe you can just start the conversation with that.
Yeah, we often identify patients who have either increased atherosclerosis. We do a calcium score or a CT angiogram, and it's not obvious why they have a high plaque burden. Maybe they're not, 20-year brittle diabetics or heavy smokers, and yet they still have a lot of atherosclerosis. And we check an Lp(a), and it's often quite elevated. And that gives you the kind of the genetic, determination of why they have this risk. I think, the Europeans, interestingly, have already recommended that everybody get an Lp(a) measurement at least once in their lifetime. We're not quite there yet in the US. I mean, Seth, why do you think we're not quite as adamant as the Europeans?
Yeah, so that's interesting. I think we're behind the Europeans in a lot of things with LDL and Lp(a) and a bunch of other cardiovascular issues. But I think it's a great point that you're bringing up at the outset of this conversation. I'm certainly disturbed by it. I think there should be universal screening. We know that Lp(a) is genetically determined. We know that Lp(a), when elevated, does increase the risk of cardiovascular events. We know a large number of people globally, it's 20% of people have Lp(a)s over 50 milligrams per deciliter, higher in the African populations and higher in Asians and South Asians, I should say. If it's a stable number and it demonstrates risk, we should check it. I think the reason we haven't is that there's quote unquote nothing we can do about it. That's what we say. I don't know what your thoughts are on that.
Yeah, I mean, I think having a lack of a targeted treatment to lower Lp(a) is still a little bit of a barrier. It would obviously be nice to finish the loop. We know that Lp(a) is bad. We know that it's prevalent. We know that it can be easily measured, but we don't really have a way to treat it. That hopefully it won't work out and go by the way of homocysteine, where we did a lot of homocysteine measures. We treated it and then found out that those treatments are ineffective. So we kind of moved away from it. I don't think that's going to be the case with Lp(a). And there are already several treatments that lower Lp(a) nicely, including the PCSK9s and inclisiran. So I think we have some therapies, but we have nothing approved yet, I guess, by the FDA is the problem.
Yeah, I still have a hard time with that line of reasoning, only because if even if we haven't proved that we have something that when we reduce it reduces risk, we do know that elevated Lp(a) increases risk, or at least is associated with increased risk, I guess, to be the purist. So if we can identify that, and it's an easy thing to identify, it would certainly motivate us and our patients to be more aggressive at reducing other cardiovascular risk factors that we have proved will reduce cardiovascular event rates. So why not just do that?
Yeah, and there's some interesting data that came out of the Aspirin trial not too long ago. It was a genetic test. They didn't measure Lp(a) directly, but they talked about the genotypes that are associated with Lp(a), and they showed that those patients who had genotypical associated risk, the highest quintile had a much better response to aspirin therapy as
Right.
primary prevention. So tying in LP little a with treatment with aspirin may be a very effective therapy. They showed lower bleeding risk and better event reduction if patients had these LP little a genomic risk scores.
Right.
They're still now measuring LP little a directly in that Aspirin trial, but again, it talks, I think, to what you were saying. We have some now potentially good therapies, and there are things you can do. If I find a patient with high LP little a, besides maybe now considering aspirin based on this Jack article, I'm also very aggressive with LDL reduction. At least get the LDL low, and hopefully avoid a lot of the long-term consequences of elevated LP little a.
Right. And I do the same. And it's interesting, the aspirin results. I don't know about you, but I've been using aspirin on my elevated LP(a) patients for quite some time, and that was reassuring, especially with the, I don't want to say anti-aspirin, literature, but our push away from aspirin for primary prevention anyway. So it was reassuring and encouraging that we're doing the right thing. And it kind of brings up the pathophysiology of LP(a), that it has that sort of triumvirate of prothrombotic, pro-inflammatory, and atherogenic elements. I think we need to look at LP(a) that way, and as clinicians or clinician scientists, whatever you want to call us, we need to be thinking about physiology and pathophysiology and doing things perhaps that haven't been quite proved yet, but make sense when we're in high risk situations like this.
No, absolutely. I totally agree. I think the one of the issues that I have, and I think it's confusing maybe for a lot of people, is this measurement of LP little a
Mm.
is not standardized. And for whatever reason, some labs report nanomoles per liter, others report milligram per deciliter, and the values are much different and the cut points are much different. And I think it causes a lot of confusion. So whatever assay you're using for your LP little a locally, just make sure you know your own normal reference values, because I've seen confusion even in the scientific literature where they wrote the wrong cut point based upon the wrong measurement tool. So the lack of standardization is one thing that's a little bit challenging, I think, for some people who aren't using LP little a every day in their practice.
Yeah, I think you're right. I think that's a very good point. There also are a couple of conversion equations that don't work that people have used, and they're not good. So we need to avoid those as well. I think there's also confusion about, LP(a), in that, it is this small LDL type particle with an ApoA attached to it, and the inverse relationship with the length of the ApoA to LP(a) levels and risk is confusing. I don't know your thoughts about that, but I think it confuses a lot of people.
No, I totally agree. And I think, I'm always at this level, especially in a measure that we don't use maybe as frequently as some of our other metrics that we're more comfortable with in practice. I just try to keep it pretty simple, and I try to use the same lab when I send assays for LP little a. I double check to make sure it's either reported in nanomoles per liter or milligrams per deciliter,
Mm.
make sure I have the right measurement, and then know the local cut points for risk. It's interesting. We presented some data out of the Baptist Heart Study. We did CT angiography in a couple thousand people in Miami, the Miami Heart Study, and we showed that if elevated LP little a was associated with not only more coronary plaque, both by coronary calcium or by CT angio, but also high risk plaque. So I think that we're now getting to some of the pathophysiology of seeing more positive remodeling and spotty calcifications and low attenuation plaques in those patients with elevated LP little a, kind of tying this blood measurement to now a phenotype that can explain why it causes more risk. And it's not just a small LDL particle, as you said earlier.
Right. Well, that's very interesting. Um, I just, for whatever reason, you just reminded me of this. I went back to the stability of LP(a), and in terms of measuring LP(a), that we should keep that in mind. But there are a couple of clinical scenarios where Lp(a) can shift. Things like chronic kidney disease can elevate Lp(a), hypothyroidism. It can be an acute phase reactant, so you don't want to, measure it in the midst of some bad event. And then menopause, because I have seen some very, very significant, I'm talking about 50+% increase in Lp(a) during menopause. So, back to the Europeans and the stability and that single measurement, there can be a dramatic change during some of these events. And I'm actually not sure that we should just limit ourselves to that single, the single measurement. It's better than nothing. But when somebody goes through one of these events, I think we need to understand that things can change. Lifestyle doesn't change it though, and that's, I think, a very, very important thing to highlight.
And people have to remember the statins have really no Lp(a) levels. So you don't want to frustrate a patient by measuring Lp(a), putting them on a statin, and then they get a follow-up test that doesn't show any improvement in that one measure, and then they might be frustrated that the statin is not working or something like that. But I think we have, several trials that are ongoing right now that are very promising, that will lower Lp(a) by 60, 70, 80%, and I think really have a significant impact on this metric. So I think we should be measuring it in our patients at risk. I agree with you. I think sometimes we need to think about remeasuring it. And if they're on a PCSK9 or inclisiran, we should expect to see a 20 to 30% drop, and that's something you can look for as well. So I do think there's some benefit in retesting. There was a nice scientific statement. Don Lloyd Jones, among others, were authors of it on Lp(a) recently. It was a scientific statement from the AHA. So I think that there is now more recognition of this and more more advocacy for this test to help us identify high risk individuals.
Yeah, I think you're right, and I think with multiple drugs in development now, and sort of really getting close, frankly, to having some information about risk reduction potentially with treatment. That'll be very helpful. You mentioned the statin thing, and I actually, we know that sometimes statins can actually worsen Lp(a), and I've had patients, very worried about that. Personally, given what you said before, that we have all the good outcomes data with LDL reduction, and we have yet to develop those outcomes data with Lp(a) reduction. I push through that and encourage patients to stay on the drugs that lower LDL, even if it's a sacrifice play and they increase Lp(a) to some degree. I don't know what your position is on that.
Yeah, no, I mean, I just think the data with statins is so solid. And, I think, I mean, what I learned when I was a resident and fellow, I think is still true today, that right now the treatment, if you identify somebody with a high Lp(a), is to reduce their LDL to below 70 and maybe now even lower targets
Right.
to obviate the risk associated with some of the Lp(a). And if that Lp(a) measure goes up a tiny bit or a small amount, so be it. You've lowered their overall risk by being on a statin and getting rid of a lot of the ApoB that's contained in the LDL. That statins are so effective.
And as you point out, before the PCSK9 inhibitors can have a very nice reduction in Lp(a). So if you have one of those problem patients, you can always add on a PCSK9 inhibitor and see what happens. So that's always an option.
So I want to remind people, if any one of these three events that occur that are unexpected should, I think, trigger automatically Lp(a) as part of the workup. So if they have atherosclerosis out of proportion to their traditional risk, if they have a thrombosis, Seth mentioned the prothrombotic nature of Lp(a), or if they have aortic valve calcification, those are three common diseases that are all associated with Lp(a). And I think if you're still going to be selective, and we're not going to measure it in all yet, at least measure it where it might might be causative and might help explain the underlying condition. And as we get these treatments approved, which I think will happen in the next few years, I think we're going to have a nice population of patients who we can apply these treatments to once we have a, an approved algorithm of treatment for LP little a specifically.
Yeah, I think that's a great point. I might add two other patient groups, premature atherosclerotic cardiovascular disease and FH. FH specifically because LP(a) is more prevalent in that population, and it really is devastating when you have both FH, right, and LP(a). I've seen some of my sickest FH patients with high LP(a) as well.
Yeah, no, and we can be so much more aggressive now with FH that again may be a trigger to go beyond what we're doing currently in that particular patient. If they also have a high LP(a), we can
Right.
accelerate those other therapies to get them even lower than they were before from an LDL perspective.
Right. I also would highlight the clinical research part of this whole thing. I mean, another reason, which I had neither one of us mentioned before, and now it comes to mind, to check LP(a) is there are clinical, there are trials ongoing, and there will be more. So there are opportunities for patients to engage in these clinical studies, and this is how we're going to learn whether or not there's a great benefit, and it's also it's obviously a potential value to the patients. So I would always consider that.
Yeah, and I think that's a great point. There are apheresis trials going on. There's a
Mm,
number of different drug therapy trials going on, novel therapies for LP little a. Some of them are further along, as you mentioned. Some are in phase 3 already. But I think that there's a lot of excitement here, and I do believe we'll have some positive trials. Maybe not all of them, but I think we'll have a couple mechanisms to treat. And I always encourage my patients, if they're in this phase where we don't yet have an approved treatment, is to enroll in one of these clinical trials. The other benefit of clinical trials is a lot of the patients will get rolled into active arm at the
mm,
end of the study as a long-term observation. So they might get drug for free for
yeah,
5 years. We did that with our PCSK9s. I had patients who just finished their 5-year follow-up of 4-year trial. So they were in a randomized trial for a few years, and now they had 5 years of open label on treatment for free to look at long-term safety and efficacy of the drug. So there's great opportunities, I think, for both patients and clinicians to help us learn about LP(a), when to treat it, how aggressively to treat it, and what the percent event reduction will be when we do treat it.
yeah. That's a great point about the open label extension also, because what we saw with PCSK9 inhibitors, the barriers to access were just have been terrible. They're much better now, but so you had all these patients on drug,
Right.
when they wouldn't have been able to get the medication probably. So that's
Yeah,
great.
yeah, yeah. Almost an
Yeah.
automatic refusal by insurance to cover it.
Right.
And we didn't have to go down that road for 5 years because they were just getting it in the clinical study.
That's great. Very smart. Well, I think I've enjoyed this conversation, and I don't know if you have anything else to add, but I think we've covered a lot of ground. What do you think?
No, absolutely. And again, as Seth mentioned at the beginning, this kind of dovetails off of our prior conversation, so you can look for that one as well. And I'll get a little more in-depth information about LP(a) and its association with atherosclerosis specifically. So I think it's been great, Seth. Thank you for sharing and taking us through some of this interesting data, and I look forward to a lot more in the field of LP(a) and treatment and evidence revolving around how we should be using it, when we should be using it, and more importantly, what treatments we should be using once we identify a person with an elevated level.
That's great. Well, thank you very much. Thank you everyone for joining us. We wish you a good day.